In this lecture, we're going to talk about LVADs, or left ventricular assist devices. We're going to cover what they are, what can go wrong with them, and how to approach these patients in the field. So you get toned out to a 70-year-old man, history of heart problems, heart failure, and his complaint is shortness of breath. On arrival, you see this. You see some object in the patient's chest with tubes going into his abdomen, and you realize that this patient has an LVAD. So first we're going to cover the basics of what an LVAD is and what it does. In general, an LVAD assists the left ventricle by improving forward flow of the blood from the ventricle to the proximal aorta. It does this by having essentially this motor or propeller down the bottom of the ventricle, which causes a suction event, which brings blood through the tubing and up into the aorta. All LVADs currently have similar components, which we'll now discuss in detail. There are multiple different LVADs on the market. Abbott makes the HeartMate 3 and also made the HeartMate 2, and Medtronic made the HeartWare, which is currently off the market. So the first component is the controller box. This allows for viewing of things like battery life, pump status, and any warnings. This sits on the outside of the patient, usually in a waist pack. Now here's a close-up view of the buttons on the HeartMate 3. On the top we can see the battery button, on the right the display button, and on the bottom the alarm silence button. Here we can see some indicator lights. We have the battery connection light. This turns yellow if the cable is not connected well to the battery, and the driveline connection light, which turns red if the driveline cable is not connected well. Also we have the pump running light, which will be green if the pump is running. So some other indicators on the device, we have the battery power. This shows the level of charge. So on this device, red would mean low battery and less than 5 minutes left. There are hazard alarms that will flash with critical issues. There's controller alarms, which will show you mechanical, electrical, or software issues. After the controller box, the next component is the driveline. The driveline connects the controller box to the pump inside the patient. It supplies power and settings and allows for diagnostics. Usually this inserts in the skin in the upper abdomen. Batteries supply the power to the whole system and generally are worn on a vest. The system can also be plugged into a mobile power unit. So why do people get LVADs? Well, primarily the indications are a bridge to cardiac transplant or a bridge to recovery. So if the patient has a reversible injury to the myocardium that may get better with time, they may go onto an LVAD to assist the heart until the myocardium can improve. So what could possibly go wrong? We have an extremely complex, in the grand scheme of things, relatively new piece of technology whose function is to keep a patient alive. So what could go wrong? Well, obviously a lot of things can. Now, it's important to stop here first and highlight the role of the EMS provider with LVAD patients. These patients are extremely complex, and the diagnostic evaluation to determine what could be going on is very advanced. Your role primarily is to uncover immediate life threats, treat these if possible, and most importantly for all LVAD patients is to gather much needed information for the hospital. This includes what type of LVAD the patient has, when and why it was put in, and who they are followed by, also known as their LVAD team. All of these patients have a team which follows them, and they have a 24-hour access phone number that they can call. So if the patient is unable to answer these questions, please try to obtain this information from somebody else. Also, do us a favor in the hospital and try and bring any type of charge device or cord that the family and the patient uses to charge or power the LVAD. Many hospitals that don't treat these patients often will not actually have this equipment, and we run the risk of the batteries actually running out of power on the patient while they're at the hospital. And finally, try and get these patients to the right hospital. Obviously, any unstable patient should go to the closest facility that can treat that patient, but if the LVAD center that they are followed by is just down the road from that hospital, try and get these patients there. Many hospitals do not put LVADs in and do not treat LVAD patients. So essentially, we then have to transfer the patient to another hospital. So if it is feasible to get them to their hospital that follows them, that's great. But if not, or they're unstable, then get to the closest facility. So the first step in trying to figure out what's going on with a sick LVAD patient is differentiate between issues with the patient and issues with the device itself. Obviously, they go hand in hand, but it's nice for discussion's sake to separate them apart. The top 3 patient-specific things that come to mind when dealing with a sick LVAD patient are hypovolemia, dysrhythmia, and infection. We'll go into detail on each of these. And the top 3 LVAD-specific things that come to mind when dealing with a sick patient are pump failure, obstruction, and a suction event. So what are some important things to focus on during the initial exam of an LVAD patient? So let's start with the ABCs. A stands for, well, ABCs. Checking initial breathing, basic cardiovascular state. It is important to know that you will very likely not feel a pulse in these patients. Again, they have a very weak heart, which may not actually be allowing forward flow with each pulsation, and the forward flow is actually provided by the continuous mechanism of the LVAD itself. So these patients will not actually have a palpable pulse. But this will be dependent on the device and the underlying physiology. Now, B is for blood pressure. Since there most often isn't a detectable pulse force, checking a blood pressure in these patients is very difficult. And we'll talk about that in a second. And finally, C is for call. Again, this is important for us at the hospital, but also for you. If you have that LVAD patient and they have the phone number for their LVAD team and they haven't called yet, it's okay for you to call that LVAD team and say, hey, I'm the EMS provider and I'm taking them to this hospital for this reason. That will activate the team early and get better treatment for the patient. Checking for blood pressure in an LVAD patient can be done by using a manual cuff and either a Doppler or colorful ultrasound. So we don't usually have this on the truck. So just know you may not actually be able to check a blood pressure in this patient. So then you're going to have to go for other signs of perfusion like mental status. But if you were to have something like a Doppler, what you do is inflate the manual cuff on the patient and then slowly deflate it. And once you hear flow on that Doppler or you're able to see flow on ultrasound, that would be the patient's mean arterial pressure. Ideal map for these patients is 70 to 80 for optimal pump function, but you won't be able to get a systolic and diastolic number. Now, after your initial ABCs, we can go on to more focused assessment of the patient and the LVAD. Now, for this, I like to use ABCDE mnemonic, and that's A is auscultate, B is check the battery, C, check the controller, D, check the driveline, and E, obtain an ECG. So when we auscultate the patient, we're listening for kind of a constant hum. If you think of what a clothes dryer sounds like when you hear that, that's what you're going to hear in the patient's chest. If you hear nothing and the patient should have a functioning LVAD, that's generally not a good sign. So we'll talk about looking at battery levels in a second, but you want to initially check that the batteries are present and plugged into the controller. The patient may also have an MPU or some sort of battery charger. Again, as the EMS unit, it's fantastic if you can bring these into the hospital. If you forget them, don't be surprised if the hospital crew actually asks you to go back to the house and get it, because it's very important that these batteries don't run out. The HeartMate 3 batteries take around 4 hours to charge, and 2 batteries together should supply around 10 to 17 hours of use. So now into the control box. This has a display screen, buttons, lights, and connections for batteries and driveline. So the display button. By pushing this, it cycles through settings like speed, flow, pulsatility, power, and backup battery. Now, do know you cannot change these settings, so don't be scared to push the buttons. These just show you different settings and numbers for the device, but it won't allow you to actually change anything or mess anything up. If you were to call the team, the LVAD team, while en route to the hospital, they may ask you for some of these values, and this is how you would find them. In terms of alarms, there are 2 broad types. The first is a hazard alarm. These are considered life threats and provide a continuous tone. So things like low flow, power issues, or cable connections could provide a hazard alarm. And the next group is advisory alarms. These are important but not immediate life threats. This provides a beeping tone. Things like minor power issues, minor cable connection issues, and some system controller issues. So next we want to go ahead and check the drive line and the battery wires. You want to check for signs of possible infection. Again, the drive line is actually entering into the patient's skin. So you want to look around and see if you see any drainage from it, any erythema surrounding it, which could be evidence of infection. And then we want to go ahead and obtain an ECG. An ECG could uncover something like a new myocardial infarction that's actually causing worsening heart function or a dysrhythmia. The patient's LVAD is going to be tuned to their specific problem, so if their heart gets worse for an acute reason, their settings may not be enough to stabilize them. With all the initial information, we can now focus on specific diagnoses. First, we'll focus on patient-specific ones. So one thing that could be going on is hypovolemia. The incidence of hemorrhage, especially in the GI tract, is high in these patients, reaching up to around 40%. Also, they tend to have AV malformations or arteriovenous malformations, which means changes in the blood vessels due to the continuous flow of the LVAD, which increases the risk of GI bleed. They get hemolysis because the red blood cells are going essentially through this motor. There's increased shear stress on the red blood cells, and those red blood cells can actually break up and make things like congestive heart failure and anemia even worse. And when an LVAD device begins to cause hemolysis, the 1-year mortality for this population increases substantially. So this can be a leading cause of these patients becoming sick and even dying. Generally, these patients are on anticoagulants, usually warfarin, and antiplatelet therapy. In addition, due to the mechanical stress on red blood cells and platelets, they have what's called an acquired von Willebrand syndrome, meaning their platelets aren't going to clump as well and stop bleeding. So these patients are at a very high risk for bleeding, especially in the GI tract. So next we'll talk about dysrhythmias. Now, patients with LVADs are prone to ventricular dysrhythmia, especially within the first 30 days after device insertion. Due to the fact that much of the cardiac output in these patients is device dependent, even ventricular arrhythmias can at times be well tolerated. So you may actually see a patient with VTAC, but they're going to look fairly stable because the LVAD itself is actually improving the cardiac outflow. Dysrhythmias causing decreased RV filling can lead to issues of low flow with the device. In addition, most of these patients with LVADs also have AICDs, or implantable defibrillators, which often terminate the arrhythmias in the pre-hospital phase. So we have to remember these patients have a foreign device inside of them, and they have a drive line which is going from the outside to the inside of the body. So these patients are very high risk of infection. So we need to do a full skin exam, especially at the drive line site. Now we're going to focus more on LVAD-specific diagnoses. For this, in the hospital, we're going to rely heavily on ultrasound, but in the pre-hospital phase, all your information that you're going to need is going to be from that controller box. Now, one of the scariest things I can think of is pump malfunction, where the device just stops working. This can happen for a few reasons. So one cause for this is overall pump failure. So this is complete failure of the pump itself. So on auscultation, you would not hear any hum for the device. And if you were to measure blood pressure on this patient, it would generally be below 40. Next issue is a thrombus. So again, this is a foreign object sitting inside the body. It's going to place the patient at high risk for developing a clot. This is why patients are on anticoagulants. Now in the pre-hospital phase, evidence for this will be, like I said, auscultation, not hearing a hum, or on the device itself, seeing a warning like low flow or high power. Once you get to the hospital, we'll do more workup with ultrasound labs, but this might be the information you have in the pre-hospital phase. All right, so how do we treat these patients? Well, again, in the pre-hospital phase, there may not be too much that we can do, but we'll talk about each thing that we just discussed. So For hypovolemia, if that appears to be the main issue, we'll treat these patients based on the clinical picture with either IV fluid or blood products, depending on your protocol and the ambulance that you're on. If arrhythmia seems to be the problem, we'll treat these patients the same as we treat non-LVAD patients. So if it's SVT, we'll treat that appropriately. If it's VTAC or VFib, we'll treat that appropriately. But also maybe one of those patients that you want to kind of pump the brakes on and hold off on treatment. If I had a sick SVT patient with an LVAD in the field, I may hold off on treating that patient just because they're kind of complex. If I think we can make it to the hospital fine and their vital signs are stabilized and stuff. But if you need to treat them, you'll go ahead and treat them the same you would a non-LVAD patient. Now for pump failure, this is just a worst case scenario. So it's very important to understand that we need to just determine if there's actually a low float or non-perfusing state, because we're not going to feel a pulse. Now in the field, this is going to be very tough. We likely won't have something like ultrasound to use, but we can check for other signs of intuition, look at the monitor, and try to use some other clinical measures. But when in doubt, we're going to perform CPR and ACLS just as normal.